Good evening, everyone, and welcome to our teaching session on Nothing Funny About the Humerus Fractures, which is a combined session with OR UK. My name is Nikki Evans, and I'll be co-hosting with Imogen and Hannah from OR UK and Joe, one of our mentors. So this is the timetable for this evening. The presentation will be split into three parts. So the proximal part of the humerus, the shaft of the humerus, and the distal part of the humerus. And we'll have space for 2 or 3 questions in between each segment. So if you write your questions in the chat box as soon as you want to, then Joe will keep an eye and ask those particular questions at the end of each segment. We'll probably fit in about 2 or 3 questions for each segment. Okay. So we'll then move on to some polling, and I think Mr. Kang's going to do some polling throughout the lecture as well, which we'd like you all to participate in. Of course, it's anonymous. Then we'll move on to case discussion and top tips for the FRCS. We will be recording this lecture and the questions, so if you miss any part of it, don't panic. It is recorded and it will be available on the FRCS Mentor YouTube channel and OR UK websites in due course. If you would like to participate in one of the vivas, we ask that you get in touch with Hannah as soon as you decide that you want a viva so that we can schedule it. We'll do as many as we have time for. We realize that this is quite intimidating, putting yourself forward, but it's the best way to learn. And you can rest assured that both Joe and I have been through this multiple times in your shoes. At this stage, I'd also say there's quite a few viva practice courses between ourselves and OR UK, which you can find on the websites. As always, we recommend our study guide, Concise Orthopedic Notes. This has been written by our mentors, and OR UK have these excellent books which I used for my own FRCS exam. Following the presentation this evening, Imogen will be in touch with you regarding feedback, and we'd really appreciate your input to help us improve these sessions. CPD certification is also available from OR UK if you contact Imogen. Okay, so this evening, we're privileged to welcome Mr. Neil Kang, Consultant Orthopaedic Surgeon at Cambridge University Hospital's NHS Foundation Trust. Mr. Kang combines his full-time clinical work with educational activities and is a convener and faculty on multiple regional and national courses. He is keen on the clinical application of basic science in orthopedics. As you all know, one of our mentors, Shwan Hanari, is also. And Mr. Kang is Director of Education for the East of England Higher Surgical Training, Rotation and Trauma and Orthopedics, as well as Associate Lecturer for the School of Clinical Medicine in Cambridge and a member of the ODEP Shoulder Board. I'm sure we're all going to learn a lot from him this evening. So without further ado, I will pass you over to Mr. Neil Kang. Thank you.
Thank you very much, Nikki. I'm going to share my screen. Right, so 3 parts to the talk today. First part, let's go for it, proximal humeral fractures. And hopefully you'll see that there are themes in common with all of today's talks. Firstly, decisions and incisions. Secondly, pattern recognition. And thirdly, a few technical tips that will hopefully help you manage these better. Starting off with our proximal humeral fractures, what kind of decisions and incisions do we have to make? Well, here we have a classical example of what presents at the beginning of COVID in lockdown 1, March 2020. What would you do with this, or what would you recommend for this patient? Well, because of COVID and the pandemic, much of our decision making was challenged, and we had to use non-operative methods. And in fact, it did go on to heal, but as you can see, it didn't heal very well. And unsurprisingly, she didn't have a great result. So decision number 1 is always going to be, are you going to operate or not operate? And this is going to be multifactorial, depending on the amount of displacement, the number of fragments, and also the fitness for surgery of the patients. But ultimately, it will be a shared decision between you and the patient. So another example of pre-COVID management, you can see here a 3-part fracture with the greater tuberosity in the neck. And this one went on to heal just as you would expect, and much better movement and less pain than the first example. So displacement did give an idea of how well we're going to do. But if you are going to go for non-operative, then I would recommend that you are aggressive with your physiotherapy, and that you make sure that they do get good physiotherapy. There are some videos on the Cambridge University Hospital's website for and at different stages, as demonstrated here by my physiotherapist Laura. And if you get the patients engaged with those on, then the outcome usually is better, and that's what we probably found from the paper, which we'll come across later. So here's another example: smashed up 4-part proximal humeral fracture in a 51-year-old here. This is a slightly older patient, 80 years old, completely displaced, and then a young person, 48, and you can see that the head is subcoracoid. So of quite a variety of scenarios that you could be presented with in the exam and in real life, which is more important, isn't it? And because if you face these in real life and know how to deal with them in real life, then the exam will be a breeze. First, the paper that I want you to think about is this one from the Edinburgh group and Clement et al. In the Bone and Joint Journal in 2014, and basically the 10% mortality at 1 year. This is a sentinel fracture. Basically, it's another one of those fragility fractures that social that the patient is just at the tip of the iceberg, and you have to treat these with care and understand their whole medical problems before jumping in and operating. Next question that will come up in the exams probably is classifications. In the exams itself, classification systems aren't required, but if you are going to classify it, what classifications can we use for the proximal humerus? Everyone knows about Neer's classification, the 2, 3, 4-part fractures, and whether they're associated with a fracture dislocation or not. Now, the Neer's paper talked about the degree of displacement, and it should be 1 centimeter and greater than 45 degrees of angulation if it is to be classified as a displaced part. This awesome team from Imperial College and St. Mary's Hospital, Professor Roger Emery and Ralph Hertel, a famous shoulder surgeon from Switzerland, got together and they published a paper looking at the different classification systems and the inter and intra observer variability between people reading the classification. And guess what? They found that it was crap between everyone else, between all the classification systems. So even if you've got the fancy Hertel's binary Lego model, it doesn't really correlate to a good classification system. And so I would just stick to the simple Neer's 2, 3, 4-part fracture dislocation system. Next question: what is the blood supply, and which is the predominant blood supply to the humeral head? We've all familiar with the anterior humeral circumflex.
Yes.
Hello. We're all familiar with the anterior humeral circumflex artery, and the arcuate artery climbs up the lateral edge of the bicipital groove with the long-headed biceps, but that is not the predominant artery. Chris Brooks, from when he was working at Guy's and Tommy's, published this in 1993, and he found that the posterior branch, posterior humerus circumflex was the predominant branch. Coudet et al. Saw a similar thing, that because AVN is rare and the PHC is minimally disrupted in most fractures, it is the predominant blood supply to the humeral head. If you need more evidence, there's cadaveric studies using MRI, and nearly 2/3 of the head was supplied by the posterior humeral circumflex artery. Next question that might come up in the FRCS is, how can you predict whether the humeral head will survive or will it go on to AVN? And so Hertel, that surgeon, Swiss surgeon that I mentioned earlier with the classification system and the binary Lego model, well, he did an intraoperative study. So all those fractures that he was fixing, he drilled and then put on a Doppler ultrasound to check the blood flow, and found that those patients that had a medial calcar segment less than 8 millimeters, so that's the head fragment, and if the calcar fragment where I'm pointing my cursor is less than 8 millimeters, or there was more than 2 millimeters of medial hinge disruption, then there was a higher rate of ischemia. However, his junior, Bastian, followed up those same patients and published the results of their fixation, and they found that although the ischemic heads were, although the heads were ischemic intraoperatively, only 80% of them survived. So they deemed that fixation is worth considering, even if they've got the Hertel's ischemic predictors. So decision 2, should we fix or should we replace? Well, we can ask Coldplay to help us with this. And if you are going to go for a fixation replacement, then which approach? And that's decision 3 on the tree. And to help you, because common question for the exam is what is the delta pectoral approach, or maybe even the deltoid split. These videos are both available for you to view after this course on Cambridge Orthopedics YouTube channel, courtesy of my mate Lee. So if we're going to fix, should we fix? Well, PROFA is the largest randomized controlled trial in the world about fixation versus non-operative treatment with aggressive physiotherapy. Remember that, aggressive physiotherapy, because lots of patients get referred to physiotherapy and they don't do anything. And what was the outcome of PROFA? Well, it basically demonstrated that there was no difference in the outcome, which the primary outcome was the Oxford shoulder score at 24 months. And once again, if you want a fuller appraisal of the paper, one of the alumni from the East of England orthopedic rotation, Arman Mehmezadeh, has designed a little video, and it's on our website, which you can see at the bottom there, eoeortho.com. So in the paper, you can see that the vast majority were fixed, but there was a small percentage that went on to have hemiarthroplasty during the operation. So it was a bit of a heterogeneous study, and that's why it's called a pragmatic trial. And they found that the study of operative versus non-operative treatment patients at all time points, including in this follow-up paper at 5 years, were pretty much the same. So this graph shows it all really. Look at the Oxford shoulder score, look at the different time points. Okay, non-operative had a non-statistically significant difference at 6 months, but by 1 year, it was pretty much the same. And you can tell all your patients that if you fracture your proximal humerus, that you'll continue to improve up to about 4 years after the injury, whether you have surgery or not. And then Is there other evidence besides the Proffer trial? Yes, definitely. There's loads of trials in our own subspecialty journal, Jesus, in 2011, and Journal of Orthopedic Trauma showed no difference between whether it was an ORIF and non-op or Hemi and non-op. So, basement jacks are asking, where's your head at? What are you going to do with this case? What approach are you going to take? So you've already heard about the delta pectoral and the deltoid split. Think about it. Which one will give you better access to this? And also, what other things do you have to contemplate? Well, if you look at that fracture, it's stuck under that coracoid. So my preference would be an delta pectoral approach from the front, obviously, and then you can perform a coracoid osteotomy, because otherwise it's going to be nigh impossible to get that humeral head disengaged from the anterior glenoid. Then temporarily stabilize the humeral head to the glenoid. Use your bicipital groove to line up the plate. Put in several screws and use sutures through the rotator cuff to grab hold of the tuberosity fragments, and make sure that the plate is below the level of the greater tuberosity, below the height of the greater tuberosity, so that it doesn't impinge. First screw should normally be the locking screw at the, a non-locking screw to the shaft, and then locking screws through the head, especially at the bottom for the raft and the calcar screws. Make sure none of the screws penetrate the articular surface. Now here's a quick summary of what we've just said. Decision 4, shall we go for a reverse or a hemi? Well, that's pretty much tribal, as Frankie Goes to Hollywood would tell us. And what happens if you do a hemiarthroplasty? Well, like the British weather, it is pretty unpredictable. And despite using a viper's orgy of sutures, as you can see demonstrated here in this technique, there is still only a 75% tuberosity healing rate. Here's another example of a proximal humeral fracture that went on to a hemiarthroplasty, and you can see the tuberosity well reduced to the implant. But now, 6 months down the line, where's it gone? It's vanished. So people decided that reverse shoulders might be the way forward for trauma, given that you don't need to rely on the tuberosities. And before the NJR reports were available, there was some equivocal evidence about using a reverse shoulder. And you can see from this recent NJR report that of 4,000 cases used for trauma, 2,000 were for reverse shoulder compared to 1,500 with a humeral hemi. So it's definitely in vogue. What are the revision rates for replacements following trauma? We can see the blue line, which is trauma, is rising and diverging away from the elective rates of revision. So that's a concerning feature. And here you can see the mortality figures. So pick your winners is my suggestion to you. The purple line here is actually the acute trauma, and that shows that mortality rises significantly more than those that have shoulder replacements for elective care. So do take care in choosing your patients. So what are we going to do next? Well, you've heard about Proffer. There is Proffer 2 ongoing. So if you're coming up to the exams, you would want to quote that we are looking at around the UK in another multi-center randomized controlled trial at the use of hemiarthroplasty versus reverse hemiarthroplasty, and also a cohort of non-surgical patients in those patients aged 65 and over. And for those of you who need to get a an audit completed. Don't miss out on famous C19, which is looking at retrospectively those patients that were treated with proximal humeral fractures back in the first lockdown. And that's another trial that's come out from York and Amarangan, and you can see the contact details there if you want to get involved. So enough talking from me. I want to know what you think and learn from you. So I'm going to put up a poll, and what I'd like you to do is tell me what you would do for these cases. Just trying to find the poll. So would you, A, non-operatively treat this 4-part displaced fracture and just move it? Would you, B, fix with a plate, C, fix with a nail, D, replace with a hemi, E, replace with a reverse? So I'm going to end that poll now because we've got lots of polls and decisions coming up, and it's great to see so much activity. Just give you 2 more seconds. Good. Okay. So I'll share the results, and the vast majority of you, 3/4, would like to replace this with a reverse. Okay. And a smaller majority would fix it with a plate, which is perfectly reasonable, but make sure you discuss the results with the discuss all options in a shared fashion with the patient, and hopefully that's what you'll take away from this talk, that all options are viable, but you need to share that discussion with the patient. Next example. So 48-year-old fit and healthy patient who has sustained this 4-part fracture. And what are you going to do? So are you going to A, fix it with a plate? A, non-operatively treat it and move it. B, fix it with a plate. C, fix it with a nail. D, replace with a hemi. E, replace with a reverse. So some rapid answers coming in, and I'm going to stop the poll there, and I'm going to share it. And once again, a 3/4 majority for fixing this with a plate. And D, replace with a hemi. That's not a bad shout, and I'll show you why. So if you needed a CT scan to show you where the fragments were, then there it is. So you can see that there's been lots of screws to fix that, and a coracoid osteotomy. You can see the fixation there. And then what happened? Well, 18 months down the line, it all died away. So ischemic predictor, definitely. And maybe that hemi was a better shout. Straight off. Ironically, that patient actually, once they had metalwork removed, because he's not a manual laborer, he was pretty pragmatic and hasn't wanted any surgery since. Next up, so this fracture. I'm going to show you the next slide as well, because I think it will be helpful for you. And then let's get your thoughts on what you would like to do with this one. So would you A, non-operatively treat it and move it? B, fix it with a plate? C, fix it with a nail? D, replace with a hemi? E, replace with reverse? Cool. Okay, it's a rather mixed bag this time. I'm going to share the results with you, and just under 2/3 would fix it with a plate, and then, as I say, a bit of a mixture between non-operatively treat it and replace with a hemi, but all options were used really. This one, just want to highlight on the CT, the reason I showed you the CT is you can see that it's actually dislocated out the back. And so this required an open reduction and in my hands, a fixation. But you could have nailed it. You could have just reduced it open and see if there was much displacement. If there wasn't much displacement, then you could treat it without any metalwork as well. So all options are open. Another one. So let's see if Proffer has had any bearing on your stance on the management of fractures. Here we go. So in this essentially 3-part valgus impacted fracture, would you non-operatively treat it and move it, fix it with a plate, fix it with a nail, replace with a hemi, or replace with a reverse? So it's looking good. I'm just going to end the poll there, share the results with you so you all know what each other's doing. And you can see a lot more of you would treat this non-operatively. And I think that's a perfectly sensible suggestion. A few of you would fix this with a plate, which in a 65-year-old female is, perhaps what Proffer was trying to say is the results are no better than non-operatively treating it. And then a few of you would also treat it with a hemiarthroplasty and couple with a reverse. So let's see, what did I do? This was a few years ago before Proffer, and you can see this is one I replaced with a hemiarthroplasty, and the tuberosities did heal. So got a bit lucky there. So in summary, there's going to be an increasing burden of these humeral head proximal humeral fractures, and 10% will be likely to die within a year. Shared decision making is key, and non-operative treatment is best for most. And if you are going to use non-operative treatment, be aggressive and use the physiotherapy as the Proffer regimen. I'm going to stop there and ask if there's any questions.
Hello. Yeah. Thank you, Neil, for the proximal humeral talk. Yeah, there is a couple of questions. So I think someone was a little bit, is there any, black and white in either to fix versus to replace?
That's the beauty of upper limb surgery.
Yes.
It's all about sharing all the evidence that you have, your experience. It's as we'll come across in the next couple of lectures cases. It's tribal. What you've been brought up with, whether you use a nail or a plate, whether you use delta pectoral approach, whether you use deltoid split approach, all these things. There is no binary evidence or black and white evidence that you should do whatever, whichever way. Sorry.
Okay. So you don't have, decision in what helps you in deciding either?
Yeah. So since there's something called the Hawthorne effect, where when you've been observed, you change your practice, and that's certainly something that was observed during the Proffer trial. And as a trainee myself, I was very keen to operate on everything and fix everything, but I didn't have the blessing of being able to look after those patients in the longer term. And now, as a consultant of nearly 9 years, it's you have that that luxury that you can follow up your patients, and so everything is talked to at length about the different options, and it's just what the patient wants, really. After discussion with yourself, you have the experience, you have the knowledge, but what you don't have is what that patient wants, and that's so the take-home message is just take your time and make sure you discuss everything in detail with the patient. And that's the best way to get the outcome, best outcome.
Thank you. And how to measure the medial calcar or the hinge on the X-ray?
So it was less than 8 millimeters. So if
is it from the articular surface, the medial articular surface?
If I go back for you, yeah. So if I show you some examples, I mean, that humeral head has got no medial calcar. There. Okay, so actually, here you are. There is. Can you see on my screen now?
Yes.
Yeah, I'm sharing. Okay, yeah, you can see that there is a nice bit of calcar, and actually, that probably does measure about 6 to 8 millimeters. So this would be quite borderline. But remember that they themselves publish the results later down the line and show that those ischemic predictors don't mean anything.
Yeah. Yeah.
So,
yeah. Good. Thank you very much. That concludes the questions for the proximal humerus.
Okay, right. Let's, without further ado, get on to the shaft. I mean, by the way, if anybody wants to send CBDs, I'm happy to fill those out as well. Not only do you get excellent training for your mock exams, but we can give you case-based discussions as well to validate if you want to. Humeral shaft fractures. So same pattern. It's all about the decisions and incisions and pattern recognition with a few technical tips thrown in. So here was a throwaway comment by Bowler. All shaft fractures of the long bones, humeral shaft fractures, are the most benign. Well, let's have a look. Why are they benign? Well, because we can tolerate great disturbances of the alignment of the fractures. We don't need to walk on our arms. And our shoulder and elbows have a large range of motion that can compensate for those fractures that may be malunited. My mate Graham Tiddley-Strong in Edinburgh, once again, published this paper in '98 about the epidemiology of the humeral fractures. And you can see that pattern again. There's a high energy in young adult males and low energy fragility fractures in females, which is a theme of humeral fractures generally. So let's get you engaged straight away. Pole 1. Here's a fracture that's been referred to you whilst you're in A&E. What are you going to do? Are you going to A, put this patient into a collar and cuff for gravity? B, put it into a sling for support? C, put it into an above elbow hanging cast? D, put it into a cast brace, including the shoulder and elbow? Or E, put it into a humeral brace straight away? So we've got lots of answers coming in. And slowing down now, so I'm going to end the poll, share the results with you, and you can see 50% would put this straight into a humeral brace. A few would put it into a cast brace, including the shoulder and elbow, and others would put it into a collar and cuff for gravity. So what would I do? This one, I definitely would put into a humeral brace in A&E. And what am I going to tell them? Well, I'm going to tell them that it's going to take about 3 to 4 months for that fracture to heal. Not that typical 6 weeks, the arbitrary unit of time in orthopedics. And I'm going to tell them that they may have a stiff shoulder and they may have a stiff elbow as well because of the time spent within the humeral brace. We can put them in that humeral brace straight away, as I say. Just going back to that mid-shaft humeral fracture, 3 parts, minimally displaced. what would you tell them about the healing? Oh, sorry. So, going to relaunch. Okay, so let's go back. Relaunch the poll. This type of fracture heals in greater than 95%. B, this type of fracture heals in 6 weeks. C, this type of fracture heals in 4 months. D, we need to see you every week in clinic for 6 weeks. E, physiotherapy will not help you. So I'm going to end the poll there. And you can see 60% going for C, and that's the one correct answer that I would give here, that this type of fracture heals within about 4 months. That's what I would tell my patients. All the others are not what I would tell my patients. And you can see here that first example I gave you, even at 3 months later, it's still not quite healed. It's got some bridging callus there. And then by 6 months, though, it's healed solidly. Although it's a bit angulated, it's not causing them any problems. So the bracing regimen, you can brace them immediately. You should then see them in shoulder fracture clinic or whichever fracture clinic, to teach them and their friends or next of kin about brace hygiene, demonstrate the exercises for hand, wrist, elbow, and shoulder, and see them again if they've decided on non-operative treatment following a discussion with you and a shared decision. Then they should be prepared to be in this for about 3 months, and it's probably not worthwhile bringing them back every week for an x-ray. And then you can see here that it may take up to 6 months for them to have an x-ray that shows that it has completely healed. So next question from the FRCS examiner: how does the brace work? Well, thanks to Queen, you will remember that it was under pressure. It's hydrostatic pressure compressing the muscles around the fractured bones, helping to align them. When is a brace contraindicated? If there's massive soft tissue loss, or if it's an unreliable patient, and if there's a big fracture gap because there's an increased risk of non-union. Here we have an example of when we might use it under pressure. Sarmiento published his results of 900 patients used that had a brace used, but only 565 actually had follow-up radiographs, so quite a high dropout rate. And the mean to union, you can see there, was about 3 months, but quite a range up to 22 weeks. And he also used it in open fractures, so gunshot wounds as well. And he reckoned there were no infections and quite a high union rate of 94%. What about modern day studies looking at that? Because that was the one-man band of Sarmiento. Well, my friends Graham Tytherleigh Strong and Lee Van Rensburg at Cambridge published this paper in 2015, and they found that anatomy matters. That if you're trying to heal a proximal third humeral shaft fracture, that 3/4 will heal in a brace, 90% will heal in a brace if it's the middle third, and if it's the distal third, 85% will heal. So these are quite useful figures for you to discuss with your patients. So poll 2, here are the radiographs of a healthy non-smoker, and what would you do for this? Just bring up the poll. Would you put them into a collar and cuff for gravity? Would you put it into a sling for support? Would you put them into an above elbow hanging cast, a cast brace including shoulder and elbow, or into a humeral brace? Just give you 5 more seconds. Quite a few still flying in. Okay, let's share the results. And mixed bag, so mixture probably between putting it in an above elbow hanging cast and humeral brace. So a third of you humeral brace, slightly less than last time. And let's see what we did. Us being Cambridge, we put in a brace, and you can see even braces can have complications. This guy had a problem with the reaction to the brace for some reason. Lots of people have problems with hygiene in the armpit and axillary issues, and but this guy was particularly allergic, and he didn't comply very well with the brace. And you can see there's quite a fracture gap that's appeared now. And then 3 months later, you can see that he's been abducting his shoulder because it's now angulated. So are you going to change your plan now? What are you going to say to the patient? You can imagine that I had the full frank discussion, went through the options with him, and decided in a shared fashion to go with an operation. But which approach would you take if you were going to operate on this patient? So option A, would you use a posterior approach? Option B, would you use a lateral? C, anterior. D, extended delta pectoral. E, anterolateral. And I'm assuming that we're plating and not nailing. So give you another couple of seconds, and looks like most of you have finished answering. And you can see that 41% of you would go for a posterior approach. That's cool. That's a very generalized universal approach to this fracture. And I personally go for an anterior approach, and there's no right or wrong for whichever you use, because what we'll find is that this friend, the radial nerve, will be whichever approach that we choose, and you just have to be comfortable finding that that approach that you can be safe with the radial nerve. If you are using the anterior or anterolateral approach, a little tip on how to find that radial nerve was given by an elbow surgeon called Stanley from Sheffield. And if you put the patient's hand's breadth above the lateral epicondyle, then the nerve is usually there coming out between brachialis and brachiradialis. So here we have another example, a slightly more comminuted and a more proximal third fracture. So what would you do for this patient? Are you going to put them into a collar and cuff for gravity, into a sling for support, above elbow hanging cast brace, or humeral brace? Okay, I'm going to end the poll there. Far more of you would put them into a humeral brace straight off, and I think that's fair enough. And then, what are you going to have a discussion with these in the clinic? Well, you remember that paper from Cambridge, which showed that 75% of fractures healed if they were in a proximal third within the humeral brace. And then the patient decides, okay, I'm not going to take that. I want to have an operation. So which approach are you going to take for that proximal third fracture? Are you going to stick with the posterior and A? Are you going to go lateral with B? Are you going to go anterior with C? D, an extended delta pectoral? E, an anterolateral? We've got a consensus here. I'm going to end the poll on that consensus. Nearly 70% would do option D, which is an extended delta pectoral. I think that's very sensible. All of these approaches, you need to be aware of the radial nerve, and that's the extended delta pectoral approach that I used. Note that there are lots of separate lag screws to help share the strain of the fracture. Otherwise, you may go on to a non-union. Next, another common question for the FRCS. What do we do with a humeral shaft fracture with a wrist drop or a radial nerve palsy? And here we have options A, which is recommend a brace for 6 weeks. So this happened at the time of the fracture. Brace for 6 weeks and see if the nerve recovers. B, offer immediate operation, query nailing. C, see in the clinic in 3 weeks and check Tinels and EMGs. D, offer immediate operation, plating. E, put into a humeral brace. This one's causing a bit more consternation. I can see that on the poll. And here we go. I'm going to end the poll. I'm going to share the results with you. And you can see that some of you, nearly a third, would watch and wait, basically, which is perfectly acceptable. And nearly half of you would offer an immediate operation with plating. So what should we do? Well, first and foremost is that shared decision making. Whatever you do, you need to talk it through with the patient and find out what they want to do as well. It's not just about what you feel, the evidence shows. And Shao and Giannudis have published on this in the Bone and Joint Journal. And there is a variability of the rates of radial nerve injuries according to different publications. This was a case that we had before, was a primary example of a radial nerve injury. Secondary ones occur later, either during operative treatment or on application of the brace or plaster. And management is, like everything else in upper limb, controversial. Shao and Giannudis, in their systematic review, showed that spontaneous recovery occurred in 90%. And even secondary palsies have a high rate of spontaneous recovery. EMGs aren't useful until about 3 weeks down the line. So if it's before 3 weeks, don't get an EMG. If there is no recovery, tendon transfer can be utilized and are very reliable. So in 2005, they published their paper. They found that the indications for surgery in most of the papers, including in their review, were for open fractures, the secondary palsies, high energy trauma, or patient choice, as we keep saying. And they've even come up with this decision algorithm for whether there is an indication for an ORIF following a radial nerve palsy. And I would say that it's pretty difficult to follow this, but essentially, if it's a high energy injury, if it's an open injury, if it's something that's likely to have occurred after surgery, then that's when I would operate. Or if the patient is extremely keen to have an operation, then I would. I'm going to skip over this one. We've done quite a few polls. If you do want to see a video of the anterior approach, then once again, it's available on the Cambridge Orthopedics YouTube channel, and hopefully the easy as ABC method will help you remember it. And that was the last example. You can see a long plate there with lots of lag screws. So treatment options, non-operative versus operative, lots of different non-operative treatments, lots of different operative treatments, indications for surgery, really only open fractures, possibly polytrauma is still a relative indication, a floating elbow, and then anything that may involve extensive nerve injury, and then metastases. That's something that I won't cover in today's talk because it's too much to cover. And plating versus non-operative treatment, there's another trial that's been set up, randomized controlled trial. It's called the HUSH trial, humeral shaft fracture trial, which has only just started recruiting. So the results won't be available for your exams, but you can talk about it in the exam, because what it means is that if there's a randomized controlled trial, no one knows the answer. Here's a distal third fracture. It can do equally well in a splint, or if you are going to operate, then I would recommend using this J-shaped plate, and you can see the forceps there pointing at the radial nerve, document where that crosses, and this is a posterior approach for that. There is a video, or will be a video, on Cambridge Orthopedics, and you can see it does take a long time, once again 8 months later, for that to heal. So whether we use nails or plates, as Frankie says, it's tribal. In summary, it's all about the shared decision making. If you are going to brace, then know about the hygiene and how long it's going to take the fracture to heal. And I'm going to stop there. Any questions on humeral shaft fractures?
Yes, just a couple. So does it take longer to unite a humeral fracture compared to lower limb fractures?
Good question. I don't think it does, actually. It's this fragility issue, and I have lots of patients who are in Cambridge. We are blessed with some of the greatest longevity in the country, especially South Cambridgeshire, they choose to go for non-operative treatment, and they can be in a plaster for several months and longer than a humeral fracture. But what you've discovered, probably as a consultant as well, it's never 6 weeks, and it's all about setting those expectations. If we in A&E are telling the patients that it's 6 weeks, you'll all be healed, you'll be moving your arm fine, we're on to a difficult situation, aren't we, really? And it's always going to be difficult to please those patients. But if we get them right at the beginning and say, it's going to take 3-4 months, but your outcome will be as good as if you had an operation, then it does actually really make a difference.
Good. And is there any worries from fixing a humeral fracture after 3 months, other than maybe dissecting around the radial nerve? Anything else?
It is that radial nerve, isn't it? And the callus, because there usually is quite a bit of callus and fibrous tissue around that. And in fact, because of COVID, lots of patients were choosing to not have an operation, and we've been having to do delayed open reduction internal fixations, and it does take a lot longer in terms of finding that site. But actually, the outcomes are just as good, because even the beauty of a humeral shaft fracture compared to a delayed union or non-union NORIF compared to lower limb is that you can shorten it, can't you? You can you don't need to take graft. You can just shorten it and get fresh bleeding bone. So that's one of the nicer things. The upper limb.
When are you deciding hanging costs for the patients?
I don't.
Rather, okay.
I'm a bracer. We all brace in Cambridge.
Good, brilliant. So unfortunately, we'll stop questions for the middle third now and go for the distal third.
Yeah, the distal third is the quickest, you'll be glad to know, but you'll have a full appreciation of the humerus by the end of this, I hope. So, with the help of my friend Bono, who has experienced this injury himself, is going to help us make the right decisions and incisions to have a beautiful day. you've got it. It's all about those decisions. It's all about the pattern recognition and a few technical tips. Oh, look, where is this from? It's from Robinson in Edinburgh, the epidemiology. And guess what? There is a high energy male preponderance and a bimodal distribution with the female fragility fractures of distal humeral fractures. They come in all sizes and shapes. Here's an example that's extraarticular. Next example is intraarticular, and then it's getting a little bit more displaced, and then boom, you've got a bomb gone off in that one, haven't you? So exam time, classifications, no one really expects you to have a classification, but in clinical cases, what would I use? I wouldn't use the AO classification. I find it too hard. Instead, I would recommend Jesse Jupiter's classification system in terms of describing it as a T or a Y or a lambda into the lateral or medial aspects. Bono, once again, inspiring us orthopedic surgeons. You'd think he was an orthopedic surgeon with this quote about hammering the world into shape. This is what you need to think about. Is it a supracondylar or an intraarticular? If it's intraarticular, it doesn't matter. You can still treat it non-operatively, or should you be replacing it, orifing it? And if it's supracondylar, you've still got that tricky decision of non-operative versus orif. So decision 2, if you are going to treat it non-operatively, are you going to move it like this lady on the left, or are you going to keep it fixed in that? So in that second decision is if you do. The non-operative outcomes in a very small paper, a small case series described by Batten, showed that compared to total elbow arthroplasty, we're actually very similar in terms of low pain levels at rest and activity. And the Oxford elbow score was statistically superior. However, there wasn't, or the minimal clinical difference was superior, but there wasn't a statistically significant large enough number. Complications. So although there are complications in the non-operative treatment group, they are mainly bony and non-unions, whereas with the internal fixation and arthroplasty, they are a wide variety of nerve injuries, wound dehiscence, and mechanical failure of the implants. So I'm going to put up a decision about a comminuted fracture in a young person, and I think there is it's a no-brainer that you would counsel this patient to have an operation. What approach are you going to use for it? That's the next decision. So you're in theatre. Are you going to use a tricep split and paraolecranon? Are you going to do the olecranon osteotomy? Are you going to use paracip approach? If this was your patient and they had decided with shared decision making to go to theatre, what would you approach would you take on this extra articular distal humeral fracture? Would you go A, non-operatively and move it, B, paratricipital, C, an olecranon osteotomy, D, a tricep split with the paraolecranon, or E, another approach? Oh, it's pretty 50-50. Oh, actually, it's quite a wide distribution, actually. I'm going to end the poll there, share that with you. And 40% would go with paratricipital. A few of you, nearly a third, would go with an olecranon osteotomy, and then a few would go with a tricep split and paraolecranon. Let's go on to what I did, and I used a paratricipital, so like the vast majority of you. And let's move on to the next case. All right, what approach are you going to use for this one? So it's slightly more complicated because it's intra-articular. And are you going to use, or are you going to treat it non-operatively and just get it moving? Are you going to use a paratricipital like you did in the last case? You're going to use an olecranon osteotomy, or you're going to use a tricep split with a paraolecranon approach? Or have you got another trick up your sleeve? I'm going to end the poll there because there's quite a unanimous 3/4 of you would do an olecranon osteotomy, and then a complete split between paratriceps and a paraolecranon approach. So let's see, what did I do in this one? Well, it's a paraolecranon, and you can see from these intraoperative photographs what a view you can get. And so this is through the Boyd interval and extending it back through into the lateral third, middle third junction of the triceps. And if you want to see a video on this, you can see that approach on Cambridge Orthopedics YouTube channel again. And you can see this is the result that we got from that. Now, once again, a little bit more complicated, but pretty similar. So I'm just going to jump to what I did. And like a lot of you, an olecranon osteotomy. But can you see on this right-hand picture the mischief that can occur from using a plate? And there's an avulsion, almost fracture of the olecranon there that can occur. So I always supplement it with a suture fixation through the tendon. This one, I'm confident most of you will go with an olecranon osteotomy to visualize the joint. And it looks like that there hasn't been an osteotomy. That's because this gentleman went on to have serious stiffness of the elbow, as you can imagine, and has had an arthrolysis and removal of the olecranon plate. But as you can see, I didn't remove the remainder of the metalwork because there's still this non-union on the lateral condyle, so he's still ongoing under my care. This one was used, we used an olecranon osteotomy again, but this time using a suture technique that's described by Adam Watts for simple olecranon fractures. Decision 4, what are you going to do with the nerves? So you're definitely going to decompress the nerve, but transposition is selective. So if you're asked about that, what you're going to do with this fracture and how you're going to deal with it operatively in the exam or even life, you're going to say, I'm a selective transposer. And that's because I'm going to check if there's subluxation after I've decompressed it and if there's any contact with the metalwork. The radial nerve should also be seen to be not under the plate, the lateral plate, more proximally. I remember that tip about where the radial nerve is. It's the patient's hand's breadth above the lateral epicondyle. Decision 5, what plating technique are you going to use? So you've decided on, you're going to do an ORIF, you've decided that you're going to use your approach, you've decided that you're going to selectively transpose the nerve, then you've got to make a decision on which plating technique. And there's 2 different plating techniques, whether you use a parallel plating, that's the black line, or you use the 90-90 degree plating, which is the dotted line. You can see from this paper in 2013 that there is no difference in the outcomes. Same with the complications. And so in summary, for ORIF of a distal humeral fracture, use the ABC description for the exam. A for attaching the articular fragments again. B for bridging the articular block to the shaft with bicondylar plates, whether it's parallel or orthogonal. And C for compressing the condyles through the plates. Remember that case I showed you where there was a non-union of the condyle. Tips and tricks: use a threaded wire. If you can, they act for the reduction of the articular surface. They can be left temporarily or left permanently, cut in situ if you want. And it's on I use a particular set. You don't need to use that set, but if you are going to use this Acumed plating system, by the way, I get no royalties from them, then I would recommend in the majority of cases to use the shortest plate so that it has least interference with the ulnar nerve. As you can see here in my evolution, I used to use the right-hand picture was an X-ray from a fracture that I fixed many years ago, and that I used a longer plate with the thicker screws, and here I've used a shorter plate with smaller screws. Mind the gap both in the front and the back in the olecranon fossa and the coronoid fossae to make sure that the screws do not penetrate there, and make sure that your screws are as long as possible, interdigitate, and they all go through the plate and as many fragments as possible to get the strongest construct. And you can see once again that here the girth of the screws has is different, and that 0.5 millimeter difference times 4 gives you a bit more to play with in the distal fragment. Case 6. So this looks a little bit different to the others that we've shown. It's intra-articular. It looks a bit more osteopenic. It's because it's a 70-year-old. If you need a CT scan, then here you go. And if you need more evidence that this is a comminuted osteopenic fracture, then hopefully that's been provided by the CT scan. So should you go for arthroplasty or an ORIF in these greater than 65-year-olds? Well, Michael McKee, originally from Canada and the Canadian Orthopedic Trauma Society, ran a randomized controlled trial many years ago, and small numbers which showed that the total elbow arthroplasty did much better than the ORIF, which is here in the blue on this graph, whereas the elbow arthroplasty is in red. And they published this in the Journal of Shoulder and Elbow Surgery in 2009. What if you choose to delay an elbow arthroplasty from trauma? Well, this publication from Prasad et al. In 2008 shows there wasn't statistically significant difference in outcome, but it was trending at the 7-year mark to a greater survivorship if they had early elbow replacement following trauma. Complications following total elbow arthroplasty, you can see there's a lot of them. So patients with a reoperation in these different series, you can see even in total elbow arthroplasty, you can have 1/4 of patients requiring further surgery. But in comparison to the operatively fixed patients, it's, in each of the papers, it's significantly less. So there's great data from the National Joint Registry, and you should use this for your exams. There is a section on elbows with using it for acute trauma, and you can see that there's been a massive rise in using distal humeral hemiarthroplasties, as you can see on this right-hand graph. It's become extremely popular. So the rise of the hemiarthroplasty. You can see there's anecdotal results. Here's a really good technique from Joydeep Phadnis in Brighton. He's published it in Shoulder and Elbow on fixing the condylar fragments to both the shaft and to the implant. And you can see the little tips and tricks he's given there. And he, in that same paper, published the results of hemiarthroplasties as opposed to total elbow arthroplasties. Once again, they are small case series, only 7 to 42 patients at the most. So we need more long-term data on that, and I think that will come from the National Joint Registry. But complications occur in those hemiarthroplasties as well, and you can see the nerve is usually, the ulnar nerve is the one that gets irritated the most. Pick your winners. Look at the mortality rate of those patients that had a total elbow replacement or a hemiarthroplasty for acute trauma, 20% at 5 years. So Yeah, and 13% at 4 years, 10% at 3 years, just like the proximal humeral fractures. These are usually in fragile patients, so you need to have that conversation with the patient and make sure that they are optimized. So in summary, if you're non-operative, get them moving early, otherwise they get a very stiff elbow. Your surgical approach is a la carte, selective ulnar nerve transposition. Plating technique doesn't matter which approach, arthroplasty, hemi or T. So without further ado, an overall summary of today's three topics. It's all about the evidence-based shared decision-making. There are many decisions that we use are based on tribal instincts, and there are lots of new randomized controlled trials that hopefully you are now familiar with or will go and look up, and that there is lots of data within the National Joint Registry for using arthroplasty. Fractures of the humerus are not funny, but treating them hopefully will now be fun. Thank you for your time.
Thank you very much. There's no much questions about the lower third humerus. Okay, I missed actually one question from the middle third. The brace, is it for the whole 3 months, all the time?
So yeah, nice question. That's really good. So initially, yes, it will be all the time, but the hydrostatic pressure works by adjusting the brace regularly and frequently as the swelling comes down. So in the first couple of weeks, the patient's going to be in a lot of pain. It's going to be pretty swollen, and so they're going to stay in that brace for the 24/7. You will teach them about hygiene, about auxiliary hygiene. You will ask, they won't be able to adjust the Velcro straps themselves. They'll need help from their family and friends. And so it will be good to have some sort of resource on patient information, how to do that. And that's why you bring them to the clinic as well. So you get your plaster technicians who are vital team members to help them look after that in the longer term. As time goes on, then especially after a couple of months, the patients become much more comfortable and they can take the brace off for longer periods of time, and they wean themselves out of it over that last couple of months, basically. Nice
Thank you very much. I think this is all the questions being asked. Thank you.
Thank you.
Yeah, thank you very much, Neil. That was a really interesting talk. I liked the little musical interludes as well. And yeah, I guess, the three things that I picked up that I thought were the buzzwords for the exam. And I picked three because I was always told less than 3 things a day was lazy, and more than learning 3 things a day was greedy. So the 3 things that I picked up was the Sarmiento brace and how it works. I got asked that in my Viva, and you gave a really good explanation of it. So candidates, you need to take that with you and remember it. The second one was where to find the radial nerve in those fractures. I was kind of taught wherever you want to put your plate, the radial nerve will be just at the end of the plate. But yeah, I remember the bit about the patient's hand above the lateral epicondyle. That's been asked in the exams as well frequently. And the third thing was, I liked the phrase selective transposer for the ulnar nerve. I thought that was just such a nice way of saying, because you always get asked, are you going to transpose the ulnar nerve? And the answer is, it depends on the situation. But I liked that phrase, and I think that's a nice buzzword for the candidates to take forward. So thank you very much. I had a really entertaining talk, and I'm sure that everybody's learned quite a lot. And as I said before, guys, this will be available on the websites for you to watch it again and go through it. So thank you very much. Have you got anything to add, Neil?
No, just enjoy your training. Best days of your lives. Own school. Have fun.
Great. Thank you very much, Neil.
Bye to me.
Thank you. So I'm going to stop the recording.